I'm upon the most merciful of the most gracious. My name is Dr. Mushtaq. I am Assistant Professor of Gastroenterology, GI Division, KU Hospital Research Center. Before formally starting the session, I would like to request Muhammad Quran to recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وهو الذي جعل الليل والنهار خلفة لمن أراد أن يذكر أو أراد شكورا وعباد الرحمن الذين يمشون على الأرض هونا وإذا خاطبهم الجاهلون قالوا سلاما صدق الله العظيم.
Now I would like to request Dr. Muhammad Kamal Hassan to open the session with his welcome remarks. Dr. Muhammad Kamal Hassan is Professor of Gastroenterology and Head of Department of Gastroenterology, GI Division, KU Hospital and Research Center. I will request him to open the session with his welcome remarks.
Of the 41st Annual Conference of Pakistan Society of Gastroenterology and GI Endoscopy. We are honored that today we are having the world-renowned gastroenterologists here in this hall, and I'm personally very much thankful to the American College of Gastroenterology. They were kind enough to sponsor and send their professor, Dr. Tauseef Ali, here to Pakistan to honor us this and our conference as an expert in the field of Crohn's and colitis. And today, I'm sure that it will be a very good session in enhancing our knowledge of inflammatory bowel disease, because we'll be having a cutting-edge discussion, and the scenarios are quite useful for all of the physicians and practicing gastroenterologists. I'm thankful once again to my worthy colleagues who are present here, Professor Genix Pharma, Professor Zaid Mohammad Khan, and I'm personally very much thankful to our worthy medical director, Dr. Amjad Ali, who has graced the occasion, although he was busy in another activity, but he was kind enough to postpone that, and he joined us. We are also thankful to our colleagues from Islamabad and from the different teaching hospitals. From Northwest Hospital, we have Dr. Muhammad Ali. From Khyber Teaching Hospital, we have Dr. Muhammad Imran as panel of expert. Now I hand it over to Dr. Mushtaq for formally introducing the faculty, and then we will take start. Thank you so very much.
Session is organized on navigating the challenging cases of IBD and expert insight in collaboration with KU Hospital and Research Center, American College of Gastroenterology, and South Asian IBD Alliance under the shadow of Pakistan Society of Gastroenterology and GI Endoscopy. Before starting the case-based discussion, I would like to introduce the panel of experts and honorable speaker. The panel of experts are Dr. Tauseef Ali, Medical Executive Director, SSM Health Digestive Institute and Associate Professor of Gastroenterology, University of Oklahoma. He is also Director of Crohn's and Colitis Center, Co-Chairperson, Crohn's and Colitis Foundation, Patient Education Committee, Director, Professional Development, South Asian IBD Alliance. He is also board member, SCG Institute and Oklahoma County Medical Society. He is also specialized in IBD. He has multiple publications and research papers, particularly on IBD. He has also achieved multiple awards, including ACG Governor Award, St. Luke Award, ACG Community Service Award, and Healthcare Hero Award. The next expert of the panel is Dr. Wazir Muhammad. He remained as Professor of Medicine and Head of Department, Khyber Teaching Hospital, Peshawar. He also remained as Associate Dean and Medical Director, Khyber Teaching Hospital, Peshawar. He also served as member of Executive Council and Postgraduate Academic Inspection Committee. Currently, he is Professor of Medicine and Head of Department, KU Hospital and Research Center. The next honorable expert of the panel is Dr. Javed Farooq. He remained as Professor of Medicine and Head of the Department, Lady Reading Hospital, Peshawar. He also served as President, Pakistan Society of Gastroenterology. He has multiple publications and research papers, particularly on hepatitis B and C. Currently, he is Professor of Gastroenterology and Hepatology at Life Care Hospital and Research Institute. Next expert on the panel is Dr. Muhammad Ali, Assistant Professor of Pediatric Gastroenterology and Head of Pediatric GI Division, Northwest General Hospital and Research Center. Dr. Muhammad Imran, Assistant Professor of Pediatric Gastroenterology and Head of Pediatric GI Division, Faber Teaching Hospital. We have also a distinguished guest in this session, Dr. Amjad Ali, who is a renowned breast surgeon and medical director, KU Hospital and Research Center. So, before starting case-based discussion, I would like to explain some ground rules for this session. So, this session is the total time of this session is 2 hours. So there will be 7 case scenarios regarding difficult and challenging cases of IBD. Each scenario will be presented, and which will be followed by case-based discussion under the expert guidance of IBD specialist Dr. Tauseef Ali. And the audience are required to write down the question during discussion, and they are requested not to ask question during the discussion part. They will be allowed to ask question at the end of the discussion, and they can share their questions with me on my WhatsApp number. So I will share my WhatsApp number later on. So now we are going to start a case-based discussion with the first scenario. So should we start? So first case scenario is patient 35-year-old female. 35-year-old male patient with 5 years history of ulcerative colitis presents with an acute flare. The patient has been experiencing symptoms worsening diarrhea, 10 to 12 bloody stools per day, urgency, abdominal pain, fatigue for the past week. Medical history include previously stable on mesalamine but stopped taking it 2 months ago. On examination, his heart rate was 110 beats per minute. He was tachycardic. BP is 165 millimeter of mercury. Temperature is 37.8 Celsius degrees centigrade. On abdominal examination, mild distension, diffuse tenderness, no signs, no peritoneal signs. Laboratory results shows hemoglobin of 9.8 gram per liter, CRP 125 milligram per liter, significant inflammation. So, questions for discussions: what are the key management principles when addressing an acute flare of ulcerative colitis? Given the patient's non-compliance with mesalamine and current severe symptoms, how would you approach the decision-making process for pharmacological therapy?
Thank you very much. Real world case scenario, and this comes in our practice very often. The two issues is that the disease was initially, controlled with, but the problem is with the compliance, and we see here that probably because of the compliance, the patient is presented with the acute flare, and it's a severe one. And you see the stools frequency and the hemodynamically the heart rate is high, the BP is at the lower sides, and of course the patient has got diffuse tenderness. So this is the gastro emergency, and we need to admit these patients in the hospital, and all the parenteral drugs, antibiotics, and the injectables, they are treated, and of course the patient is at the verge of that. The patient may we may lose the patient if we did not address these his main complications, his main challenges in time. So this is the thank you very much once again for this case, bringing this case scenario for our juniors. That this is really out. We see these patients. Even in the clinics, we see these patients. And the one thing is that patients are mostly here. They are in a source of. They let. I mean, being that our patient is here, they say, "It तो पहले भी होता रहा था, कोई बात नहीं है." So my take on this will be that this patient needs as an emergency care, and further how to go about. I think our colleagues will put more light on that.
So I think very interesting case where, first of all, we need to define what is the acute flare of UC. So very important for all of us to understand how do we define acute flare of ulcerative colitis. Just like you mentioned कि मरीज कह सकता है कि ये तो होता रहता है 10 बाउल नंबर से पहले के नॉर्मल है. But the important thing is how do you recognize that the patient is going into acute flare of ulcerative colitis. But before even going to that, before you define what is the definition and what are the principles when you get the management, is a couple of things that I want to point out. Number one, compliance and the education of the patient when they have ulcerative colitis. And that's our first responsibility to explain to the patient, because if you do not explain to the patient, if you don't set up the targets, okay, these are the targets we need to achieve, and what is ulcerative colitis, this is exactly what happens. The patients will stop taking their medication because they feel good. They feel like they're doing fine and they don't need to take their mesalamine therapy, and then they relapse. The risk factors where you really have to pay attention, especially in Western world, are young male patients. These patients are at high risk of non-compliance. So it's a very low-hanging fruit for all the students and trainees here to find out what in our culture in Pakistan, who are at risk of non-compliance and non-adherence. So I would recommend that if those of you who want to do any clinical study, very easy study, to find out that in Pakistan, who are at higher risk of non-compliance and non-adherence. Is it the education level? Is it the family support system? The basic understanding of knowledge? Or is it true as in Western world, young males patients who don't have partners? So that's the first thing. The second thing is compliance and adherence itself, and we can go back and talk about it. The third thing is the medication itself, that why the patient relapsed. Were we giving that patient adequate treatment with mesalamine therapy? Were we proactively checking and making sure that the patient does not relapse? Now we come to the basic definition of acute severe ulcerative colitis, and then how do we manage and what are the key principles? The first thing is this patient is coming up with more than 6 bowel movements per day. So if you look at the True Love criteria for acute severe ulcerative colitis, it's having more than 6 bowel movements per day with one sign of systemic toxicity. So one sign could be fever, tachycardia, anemia, or elevation of ESR. Later on, True Love definition came in 1950. Later on, they added CRP also. So if you have an elevated CRP, then that's also, so this patient is full-blown acute severe ulcerative colitis. These days, we are even discussing, do we need to wait that long before we call it acute severe ulcerative colitis, before we admit the patient? Because this patient is now terribly sick, having more than 6 bowel movements per day with fever, tachycardia, hypotension, elevated CRP. So these are like worsening signs. Do we really need to wait? Can we even recognize patients early on? Very nice Turkish study showing that CRP albumin ratio can really predict with a sensitivity of 80 to 90% that your patient is going into an acute severe ulcerative colitis. CRP albumin ratio of 0.6. There are some other indices also that we can use to define and identify these patients early on. So we don't let these patients go that far, that now they're having fever and bloody diarrhea and pain. This patient is almost at the verge of getting fulminant ulcerative colitis. So now this patient comes to the hospital. The first principle is to rule out infections. So you want to rule out infections by doing stool studies, because an infectious colitis can also present with similar symptoms and signs: fever, tachycardia, hypotension, bloody diarrhea, E. coli, salmonella infection, C. diff infection. Even patients, this patient is not on any immunosuppressive therapy, but if this patient is on immunosuppressive therapy, you have to rule out some viral infections also like CMV. So the first basic principle is ruling out infections. The second is performing a quick flexible sigmoidoscopy. Studies have shown that if you perform a quick flexible sigmoidoscopy, within 2 days of admission, the outcomes are better. The use of steroids is less and the risk of surgery is less, because that can really dictate you how you want to do it. And then the third principle is giving them IV steroids and defining a time. That, okay, we're going to give IV steroids, but only for 3 days. And if it is not working, we are going to advance therapy, or we're going to call our surgeon, preferably a colorectal surgeon. Because if you do surgeries, an elective surgery versus an emergent surgery, the mortality is higher if you do it an emergency surgery. So these are some basic principles, and we can go into details. But two other things, when you manage an acute patient with ulcerative colitis, even if they are having bloody diarrhea, as long as their hemoglobin is not dropping very fast, these patients are at higher risk for DVT for many reasons. These patients are bed-bound, these patients are on steroids, these patients are malnourished. So all these are risk factors to develop a DVT. So these patients should be offered DVT prophylaxis. So there is no reason to withhold an anticoagulation in a prophylactic dose in these patients. And then the third principle, or third important thing, is nutrition. Studies have shown, and our neighbors, Indians, have done a really good job in doing research on acute severe ulcerative colitis. And they have actually shown that if you give them nutrition, enteral nutrition, with steroids, the response to steroid is even better compared to patients who don't get enteral nutrition through NG2 nutrition. So these are some basic principles that I have to share, at least in the beginning, and we can talk more about each thing as we move along. So I think a very interesting case where, first of all, we need to define what is the acute flare of UC. So very important for all of us to understand how do we define acute flare of ulcerative colitis. Just like you mentioned कि मरीज कह सकता है कि ये तो होता रहता है 10 बार नंबर से पहले ये normal है. But the important thing is, how do you recognize that the patient is going into acute flare of ulcerative colitis? But before even going to that, before you define what is the definition and what are the principles when you get the management, is a couple of things that I want to point out. Number one, compliance and the education of the patient when they have ulcerative colitis. And that's our first responsibility, to explain to the patient, because if you do not explain to the patient, if you don't set up the targets, okay, these are the targets we need to achieve, and what is ulcerative colitis? This is exactly what happens. The patients will stop taking their medication because they feel good. They feel like they're doing fine and they don't need to take their mesalamine therapy, and then they relapse. The risk factors where you really have to pay attention, especially in Western world, are young male patients. These patients are at high risk of non-compliance. So it's a very low-hanging fruit for all the students and trainees here to find out what in our culture in Pakistan, who are at risk of non-compliance and non-adherence. So I would recommend that if those of you who want to do any clinical study, very easy study, to find out that in Pakistan, who are at higher risk of non-compliance and non-adherence. Is it the education level? Is it the family support system? The basic understanding of knowledge? Or is it true as in Western world, young males, patients who don't have partners? So that's the first thing. The second thing is compliance and adherence itself, and we can go back and talk about it. The third thing is the medication itself, that why the patient relapsed. Were we giving that patient adequate treatment with mesalamine therapy? Were we proactively checking and making sure that the patient does not relapse? Now we come to the basic definition of acute severe ulcerative colitis, and then how do we manage it? What are the key principles? The first thing is this patient is coming up with more than 6 bowel movements per day. So if you look at the True Love criteria for acute severe ulcerative colitis, it's having more than 6 bowel movements per day with one sign of systemic toxicity. So one sign could be fever, tachycardia, anemia, or elevation of ESR. Later on, True Love definition came in 1950. Later on, they added CRP also. So if you have an elevated CRP, then that's also, so this patient is full-blown acute severe ulcerative colitis. These days, we are even discussing, do we need to wait that long before we call it acute severe ulcerative colitis, before we admit the patient? Because this patient is now terribly sick, having more than 6 bowel movements per day with fever, tachycardia, hypotension, elevated CRP. So these are like worsening signs. Do we really need to wait? Can we even recognize patients early on? Very nice Turkish study showing that CRP albumin ratio can really predict with a sensitivity of 80 to 90% that your patient is going into an acute severe ulcerative colitis. CRP albumin ratio of 0.6. There are some other indices also that we can use to define and identify these patients early on. So we don't let these patients go that far, that now they're having fever and bloody diarrhea and pain. This patient is almost at the verge of getting fulminant ulcerative colitis. So now this patient comes to the hospital. The first principle is to rule out infections. So you want to rule out infections by doing stool studies, because an infectious colitis can also present with similar symptoms and signs: fever, tachycardia, hypotension, bloody diarrhea, E. coli, salmonella infection, C. diff infection. Even patients, this patient is not on any immunosuppressive therapy, but if this patient is on immunosuppressive therapy, you have to rule out some viral infections also, like CMV. So the first basic principle is ruling out infections. The second is performing a quick flexible sigmoidoscopy. Studies have shown that if you perform a quick flexible sigmoidoscopy within 2 days of admission, the outcomes are better. The use of steroids is less and the risk of surgery is less, because that can really dictate you how you want to do it. And then the third principle is giving them IV steroids and defining a time. That, okay, we're going to give IV steroids, but only for 3 days. And if it is not working, we are going to advance therapy, or we're going to call our surgeon, preferably a colorectal surgeon. Because if you do surgeries, an elective surgery versus an emergent surgery, the mortality is higher if you do it an emergency surgery. So these are some basic principles, and we can go into details. But 2 other things, when you manage an acute patient with ulcerative colitis, even if they are having bloody diarrhea, as long as their hemoglobin is not dropping very fast, these patients are at higher risk for DVT for many reasons. These patients are bed-bound, these patients are on steroids, these patients are malnourished. So all these are risk factors to develop a DVT. So these patients should be offered DVT prophylaxis. So there is no reason to withhold an anticoagulation in a prophylactic dose in these patients. And then the third principle, or third important thing, is nutrition. Studies have shown, and our neighbors, Indians, have done a really good job in doing research on acute severe ulcerative colitis. And they have actually shown that if you give them nutrition, enteral nutrition with steroids, the response to steroid is even better compared to patients who don't get enteral nutrition through NG2 nutrition. So these are some basic principles that I have to share, at least in the beginning, and we can talk more about each thing as we move along.
Any questions or comments from pediatric gastroenterology colleagues? You facing challenges in your practice?
Yes. Sir has very beautifully highlighted the initial presentation of acute severe flare of ulcerative colitis. But moving to further management of this acute severe flare in acute ulcerative colitis, there are many, after starting the IV steroids, in old days we were doing the Pukai scoring to know how much these patients are responding to the IV corticosteroids. But now there are many criteria like CRP and number of stools in which predict the response to the IV steroids. So if the CRP is going down and the number of stools are decreased from, they are telling that if the frequency is less than 3 at 5th day applied, so these patients are responding to the IV corticosteroid. And if the stool frequency is more than 8, or if the CRP is more than 100, so meaning that these patients are not responding to IV corticosteroid. So at day 5, we can move to the second line therapy. And in the second line therapy, we have tacrolimus and infliximab. These are the second line therapy to start at the day 5. And if they are not responding to this therapy on day 10 or to 15, so we can then move to surgical management.
Another important thing I would highlight that in case of ulcerative colitis flare, we have to rule out infections like Clostridium difficile infection or CMV colitis. These are important to be ruled out because these can cause acute exacerbation of ulcerative colitis. So these are important to be ruled out in any case who presents with acute flare.
What is the role of antibiotics? Like, do you guys give antibiotics here, like to patients who are admitted with acute severe ulcerative colitis, or you don't give antibiotics, just steroids? How do you manage the antibiotics in these patients?
We, by tradition, we do give antibiotics. The reason is the cultures and all those things, and we are really living with the zoo of the bacteria and all those things. So, by and large, we start with the antibiotics. We don't take the risk. So, this is one thing. Though it may not sound well that each in every case, but because what we've seen that yes, the antibiotics does play a role because we are prone to all these things. Second point, this very well point was the compliance. Our compliance is poor for two main reasons. One is, of course, here is the out-of-pocket approach. Our patients have to pay for the drugs. There is no like such insurance system or something like that. So mostly, and especially for outdoor, the patient has to purchase the drugs and take care of that. Second, what we have seen the problem with our female patients, because our female patients, they present with the acute flare, and the reason is they are dependent upon their male family members to bring for them the drugs and all those things. And second, our females are not very much, they don't complain or explain that much. Where they complain, it's really very extreme. So, and second, that our patients in one way or another, they're very, resistant to understand that this is a lifelong disease. They have to take the medicines. And when we tell them, especially in the long-term cases, the surveillance and colonoscopies for tumors, even then they say, why? I'm all right, why should I do that? So there are so many issues and so many challenges in managing these patients. Even in the maintenance phase, it becomes more difficult to convince them to take the drugs and all those things. So it's really multi-pronged sorts of problem for our gastroenterologists that we face.
Well, a comment here about the antibiotic in my own experience. So, when you come back from countries like UK and US, and you see a different kind of antibiotic approach, obviously it takes time to acknowledge that and the limitations. क्योंकि अब breast surgery जो है वो clean surgery. What we do is 90% surgeries में हम antibiotics नहीं देते. Only few, और जिसमें antibiotic देते भी थे तो that would be just a shot of antibiotic at induction and that's it. So I came with that approach, with that mentality, and the infection rate was very high. And then I realized it's not just antibiotics, you have to keep the whole sterile chain. And that doesn't just start and end with antibiotics. There are a lot of other factors. along with, as Professor Faruqi said, कि जो हमारी जो antibiotic resistance है, जो हमारी जो वो चीजें हैं, तो that's completely different. From surgical point of view, ये जो case है IBD और उसका, although as I said I'm not a colorectal surgeon, but we've managed them as part of our training, और जो audience है उनके लिए के सिनेरियो डिफरेंट होता है. प्राइवेट प्रैक्टिस में यू वांट कि सारे पेशेंट्स आपके हैं, लेकिन जब आप गवर्नमेंट सेटअप में होते हैं या ऐसे सेटअप में होते हैं तो देन यू ट्राई कि नहीं ये पेशेंट सर्जन का है, नहीं ये पेशेंट मेडिफिजिक गैस्ट्रोएंटरोलॉजिस्ट का है. सो जो फर्स्ट डिसीजन यूजुअली इमरजेंसी में ऐसा पेशेंट आता है ऐसी जगहों पे, तो ये है कि डज दिस पेशेंट नीड सर्जरी या मेडिकल मैनेजमेंट. मेडिकल मैनेजमेंट की डिटेल तो कोलीग्स ने बहुत डिटेल में बता दी, लेकिन जो फर्स्ट होती है, स्पेशली इफ पेशेंट इज हेमोडायनामिकली अनस्टेबल, स्पेशली इफ देयर इज सिग्निफिकेंट एब्डोमिनल टेंडरनेस, तो the first question that would need to be answered is always, does this patient need acute surgery? और उसमें दो तीन basic, correct me if I'm wrong, दो तीन basic indications है. If there is evidence of perforation, if there is impending perforation, या फिर जिस तरह ये वाला केस है, कभी कभार there is failure of medical management. तो अगर एक्यूट सिनेरियो में आपको IBD ऐसे कोई केस आता है, वो हेमोडायनामिकली अनस्टेबल और सिग्निफिकेंट एब्डोमिनल टेंडरनेस है, तो फ्रॉम अ सर्जिकल पॉइंट ऑफ व्यू, यूजुअली फ्रॉम बोथ पॉइंट्स ऑफ मैनेजमेंट पॉइंट ऑफ व्यू, द फर्स्ट डिसीजन इज यूजुअली कि डज दिस पेशेंट नीड सर्जरी और मेडिकल मैनेजमेंट, एंड देन यू गो अलोंग विद मेडिकल मैनेजमेंट. थैंक यू.
I'll just add 2-3 lines and we can go to the next case also. The role of antibiotics. I have a very different training from some experts in IBD, where the way I was trained was that in IBD, the antibiotics such as ciprofloxacin and metronidazole are not just antibiotics, but they also have some immunomodulatory role also. So using them sometimes makes sense. Apart from controlling and addressing infections, and sometimes, as you were saying, that cultures may take some time. It may take us 2 or 3 days to get the cultures back and find out, so you empirically start that. So sometimes you have to use that. And in fact, if you look at some of the pediatric IBD data from Israel, they used to call it Jerusalem cocktail. So if you look at the Jerusalem cocktail, they actually use 4 antibiotics to treat acute severe ulcerative colitis with some very good results. So I think there's still some role of antibiotics, although the guidelines, if you look at the guidelines, they actually say that do not use antibiotics. But I think we have to sometimes keep these things in mind, that sometimes what you practice may not be in the guidelines, because the guidelines are just there to guide you and not tell you exactly what to do with the patient that is in front of you. The second point I would make for the surgeon, as you were saying, there is this concept of calling the surgeon when there is really need for surgeon. What we do in the United States mostly, we introduce the surgeon right from the beginning. So the patient is coming with acute severe ulcerative colitis, I'm starting the IV antibiotics, and I'm calling my colorectal surgeon to come introduce himself. So the surgeon will say to the patient that we are giving you 3 days, and if in 3 days you're not getting better, or in 5 days you're not getting better, you're going to go for surgery, and this is how the surgery will look like. So you are actually preparing the patient, and it's not a last minute panic that tomorrow you're going to the OR to get your colon removed. So you are preparing the patient along with giving them steroids, so both options are there.
Because we have a lot of economical states here, so we have to think 100 times before prescribing painkillers to the patient. We can't go for cultures, even flexible microscopy every time is a problem. So, what will you recommend? What minimum possible tests we can do to differentiate between infectious colitis, any clues from your experience, and acute flare? And second, will you recommend to start empiric antibiotics in all patients?
I think that's where I'm here to learn from you guys how you do it. But because you can't give steroids if there's a suspicion for infection. One thing that's kind of like point towards infectious colitis is taking a very good history and fever. It's kind of like rare, especially in the United States, when you see the US patient population. When they have acute severe colitis, fever is not their presentation. So if someone is coming with fever, you really want to rule out infection viral infections and other infections. Sometimes we do start them on empiric antibiotics because just like here, it is hard if we have a patient coming from somewhere else getting a transfer, they may also not get the stool cultures done in a timely fashion, and the clock is ticking and you have to start steroids. And if they're not getting better in 2 to 3 days, then you go back and see. But fever, I think, is one important thing, and then just taking a good history. A lot of patients will come and tell you, yeah, I had a chicken sandwich, I had something that I ate, or a family member was also sick, and everyone in the house was sick, and I got sick. That really points toward more of an infectious etiology. This patient clearly had stopped the medication, but what if this patient was already taking medicine, and despite that got flared? That may be another reason to say, well, I must check cultures first before I do anything else.
He's stick to medication and then even then he's symptomatic. Then of course you have to rule out. Otherwise, most of the times it's a pure case of non-compliance. You don't need to give antibiotics at all. But in our practice, like we practice in Pakistan, the problem is that it's a cocktail, as Dr. Tauseef mentioned, it's also a cocktail. We have our own cocktail. We use antibiotics and steroids and everything, whatever is available. The objective is to, make the patient symptom-free. So it may be a cocktail which works for us, but it may be something which is not approved by the guidelines, or not recommended by the guidelines. Anyhow, it's a clear type of area, and clear-cut decision-making depends purely on the consultant or the doctor who is treating the patient, like the way you practice. But these are the different ways and means you can go about. Next case.
I have read a discussion on managing their ulcerative colitis, so let's move to the next scenario. 31 years old woman with history of ulcerative colitis for the last 3 years. Currently, she is on mesalamine 4.8 gram per day, intermittent use of mesalamine, topical mesalamine for the last 3 years. Previously, she achieved clinical remission with starting prednisolone 40 mg daily. Symptoms return 6 to 8 stool per day. Frequent bleeding urgency when taking steroids below 20 mg per day. Investigation, Gastrian website was negative. CMV stated there was no evidence of CMV. Key issues: steroid dependency. The patient has never been in prolonged steroid-free remission, and the symptoms recurs as prednisolone has tapered. Question for discussion: given the patient's steroid dependency and inadequate response to mesalamine, what are your treatment options beyond corticosteroid in managing moderate to severe ulcerative colitis? In the source limited setting like ours, how would you approach the initiation of biologics and immunosuppressive therapies for this patient?
So the first thing is the steroid dependency and the inadequate response to mesalamine. One basic principle that we have learned in the last few years, and I'll come to steroids in a second, but I thought to kind of like supplement our previous discussion also about compliance and patients' understanding, our own understanding also. What we have learned over the last 5-6 years now, that symptoms and inflammation do not correlate. And the very first meeting when I have a patient, I tell them two basic, I tell them this is my perspective on Crohn's and colitis. Number first, that symptoms, which is urgency, diarrhea, abdominal pain, and inflammation, they don't correlate. So I explain to them that you can have lots of symptoms, but no inflammation. Or vice versa. You can have no symptoms, but still inflammation. So it's important to control symptoms because that gives them quality of life. Nobody wants to go to the bathroom every 15 minutes. So that gives you a quality of life. But it is equally important, actually more important, to control inflammation. Because if you have silent inflammation, that is a risk factor for disease progression. They can get injuries. So I need to control your inflammation even if you are not having symptoms. Then the second part is what I tell them, that we have 3 buckets to fill. The first bucket to fill is symptom control without steroids. The second bucket is we need to control your inflammation. So we need to check your calprotectin, which is the stool test, or CRP. In ulcerative colitis, typically these days we do a stool test called fecal calprotectin. I don't know if it's available here. So we do that, and my personal target is 200. You need to bring the calprotectin below 200. And then the third bucket to fill is healing of the bowel. I need to, at some point, do your colonoscopy to see if everything is healed. And we are not going to stop until we fill these three buckets. So if you have that conversation, two things can happen. Number one, the patient will understand that I just don't need to stop if my symptoms are better. And I just don't need to keep taking steroids because they are bad. And then the second, compliance. They will not stop their medication and continue and will engage with you. So now the steroids, this patient cannot go below steroids, 20 milligram. So I have a question for all the students and trainees here. So I know you are going to ask us questions, but I'm asking you a question. So volunteers, let's enumerate some of the side effects of steroids. Because the patient can come and say, so what's wrong? I do actually really good on 35 milligram or 40 milligram of prednisone, and my life is so better. Why are you so worried about me not taking steroids? I've been doing so well, and you keep telling me stop steroids, and I stop my steroids, and my symptoms come back. So what's wrong here? And I've done it so well for the last 6 months. So why you are so nervous about me taking steroids? So what are the side effects of steroids? So just randomly tell me the side effects of steroids. At least 6 or 7 side effects of steroids. One side effect.
The one side effect of the steroid is that it causes kidney failure. Sometimes it also causes kidney stone.
Okay. That's rare, but okay. What else? Common side effects of steroids.
Water retention in the whole body.
So you get weight gain, water retention, that's one. Maybe more important for the female, especially in Western world, they don't want to look, the body dysmorphia is there. So what else? What are the common side effects of steroids? That's one or two. Just name it, you don't have to just shout out. You don't have to be looking at you, just say it. Abby is good, 3. We got 3 so far. Yeah, actually it's a thinning of skin. Thinning of skin, okay, very good. 4. Muscle weakness, myopathy. One of the important things for these patients, if you ever watch them, it's an excellent one, often missed, is muscle weakness. These patients, when you see them in the clinic, and the way I detect that they are on steroids, they cannot stand up from a chair. They have to put their hands or there and then they stand up because they have proximal myopathy. So that's how you find out that they're on steroids. And someone mentioned here something. Yes, insomnia, sleep disturbances, fragmented sleep. And you know, poor sleep, that was my area of research many years ago. And we discovered that poor sleep increases your flare 2 times. So it's kind of like a vicious cycle. So we got sleep, we got skin. So 1, 2, 3, 4, 5.
Diabetes.
Yeah, 2 more. Blood pressure, high blood pressure, hypertension.
Irritation.
Yes. Yes, so adrenal insufficiency, you can suppress your adrenal. So then when you stop your steroids, you get into crisis or withdrawal. Yes, that's good, peptic ulcer. And then bruising, yes. And then the last one I can mention is cataract, right? So you can get cataract. So infections, that's good. So if you tell these 7 or 8 side effects, I think you will scare the patient, right? That you can lose your vision, you can get cataract, you can lose your bone, you can get fracture. In the United States, if you do not tell your patient that if you're on steroids and you can get fracture and the patient get fracture, he can sue you. We had a cook, a chef, who was on steroids and nobody told him that you can get a fracture, and that poor guy got a fracture because he fell down and he was on chronic steroids. So he sued for almost $5 million, and he won the lawsuit for that because nobody told them about that it can cause fracture. So it's very important for two things. Number one, telling the patient that why steroids are bad, and second, to help them understand why it's bad and why they need to be on medicine. So now the question comes, mesalamine therapy, why this patient needs steroids. So I think this patient, if you look at, was on a good dose. 4.8 is a good dose of mesalamine. What can you do if patient has, let's say, left-sided colitis? They are on 4.8 grams of mesalamine and they're still not feeling quite there, still having some symptoms. And their symptoms are mostly urgency, frequent going to the bathroom. What else can you do to those patients? So studies have shown that you can actually start using topical mesalamine. Combination of mesalamine orally and topically is better than just giving them monotherapy, because many times they have proctitis. So if you look the history of ulcerative colitis, it starts from rectum, right? And it goes all the way up to the cecum. When it starts getting better, it's the reverse way. It starts from cecum and it starts getting better. So rectum is the last part to get better. So many times when you give oral mesalamine, you get better, but you still have the rectum that is inflamed. And if you look at the rectum physiology, it has to have a lot of compliance and elasticity to store your feces. If you don't have that elasticity or compliance, then you have to go to the bathroom all the time. And this is what's happened. So giving them some suppository, some enemas can really help them. Before you even think of giving them steroids, think of giving them topical mesalamine. And then the second question comes, which I think I'm going to defer to our experts here from Pakistan, that what is their choice if mesalamine is not working? And then I can tell you what my choices are in those patients. So I think I'm going to open the floor here.
What's up? Thank you for elaborating the case. Usually it is the steroids, it's not only for the IBDs, but it is a problem with the systemic sclerosis and with the SAD, with the rheumatoid arthritis. When the patient becomes fed up of steroids, they become puffy, they become iatrogenic, Bushingoid. So these are the areas where you must add a steroid-sparing agent before the development of the steroid side effects. We commonly use azathioprine as a steroid-sparing agent and see for the response. But as far as the acute flare-up is concerned, then you have to use the corticosteroids either intravenously or locally. In our own practice of physicians, I'm working as a general physician, so we use steroid enemas in these patients with acute flare-up and with the steroid side effects, and that worked very well. And the third thing is now the newer drugs like the biologicals, if they are considered by the expert gastroenterologists to introduce that before the development of these side effects of the steroids. Thank you.
These azathioprine, so we commonly use drugs. 6 market for taking, but mostly we are working on azathioprine that we are getting good results. The biologics, yes, we go there, but this is a third line. The reason is it's costing and all these things. Personally, me, the Kamran has got more experience in taking these as compared to me. But the second at the prompt action, when the local and the steroids and these are going to fail, so we go for, and the patient is steroid dependent, then we go for azathioprine. This is the company we use. Not only for IBD, for any steroids requiring conditions. Kamran, you more from this will you.
Sir, as mentioned, like this is our common practice.
Yeah.
Most of the time, it is pain colitis with severe symptoms as first presentation to the patients. I usually start steroids, nasacol, and azathioprine altogether. Then I wean off steroids after 8 to 12 weeks. and the patient usually do very well with the two drugs combination, azathioprine and azathioprine. But there are quite a few cases who still do not improve with this regime and they still are symptomatic and they become steroid dependent. So in that particular scenario, it's a very big challenge for us. We know about the Western practices like I had fellowship from Japan. They have a top approach. They first hit with biologics and then But in Pakistan, it's step ladder approach. We start with the steroid and azathioprine and azathioprine, and then we reach to the biologics. It's a big challenge economically, and I had a discussion earlier this morning with Professor Tauseef Ali that getting biologics is a big challenge, and we have to go to the Bettermark or to some other sources because it is not covered by the common health insurance policies right now in this province. So this is a common practice, and if patient can afford biologics, we start with Infliximab, and if they can't afford biologics, then we admit them, we keep them on steroid, we try to arrange biologics by some other sources like Zafar or Betamala. This way we go about it.
Thank you, Sri. I think we should go to the next year. This was so nice and elaborative talk on melting steroid dependency.
Quick 1 minute. I'll take 1 minute. One thing that we have, and I just want to introduce this and see if you want to do any future studies, because my personal experience has been really, really good, is the use of curcumin. So there are actually now some experts also recommending to use curcumin, turmeric. The curcumin, the dose is about 1000 BID, 1000 milligram. So in the United States, it's actually available over the counter also. Yeah, to haldi so haldi. So I think I would encourage to do studies on it, because remarkable results of curcumin along with mesalamine, 1000 milligram twice daily. And actually there is a compound that I don't think so, unfortunately we can get it in Pakistan because it comes from Israel. It's called CurQD. So there were two scientists, physician scientists, who went to China and India. So they got the curcumin from India and QD, Qingdong from China. So they compound this called CurQD. So it's now available in the United States also. So we use that, and remarkable results. So I think in a resource-limited country where we can't use biologic, sometimes you have to resort to this herbal treatment and supplemental treatment or Ayurvedic treatment to see if we can do even studies and prove that it actually can really help. Having said that, the second thing is never forget about, I think we are lucky that in Pakistan, what my experience is coming here frequently, that a patient do respond to azathioprine. In the United States, it's very hard to find a patient who has a beautiful response to azathioprine. You have to go to biologics and sometimes even skip azathioprine. But in Pakistan, I heard that azathioprine really works good. So the key thing is that you start the drug azathioprine a little bit earlier than what we typically do. Don't wait the patient to fail mesalamine. Maybe proactively check their calprotectin. And if it is high, just go ahead and give azathioprine, because your best bet is to use these drugs early on. So don't delay the use of azathioprine just because the patient is telling you that he's doing good. Maybe check calprotectin, and if it is still above 200, introduce azathioprine if possible. And last comment, optimization of azathioprine. In the United States, we check metabolites, right? So 350 is where we want to be. It's very expensive here. So I think one thing that I learned from my seniors, when even in the United States we didn't have these tests, is leukopenia. So look for leukopenia. Once your patient is getting a little bit leukopenic, it means you've given them enough azathioprine. So push azathioprine until you see a little bit drop in your white count or leukocytes, so that you know that now you have given them enough azathioprine. So just some key tips.
Can I ask a quick question? Sorry, apologies. Because it's related to आपने हल्दी की बात की, कुरकुमा की बात की, तो एक चीज जो है for the whole panel के is it true कि जो IBDs की जो incidence है, जो patients हैं, is there a difference in the incidence of ulcerative colitis and Crohn's disease in the Western world and in the Asian subcontinent? And if the general perception है कि यहाँ पे patients कम, could that be related कि हमारे जो spices, जो मसाले, जो cooking है, उसमें routinely curcumin use होते हैं? So are these two related? Is it true, and are these two related?
So that is my state-of-the-art lecture day after tomorrow. So come and attend that, and I have my answer on that epidemiology of IBD in Western world and in East, like in South Asia. So that is why, if you heard, I'm part of the actually chair of the Professional Education Committee for South Asian IBD Alliance, and this is exactly what we are studying. That patients that are from South Asia, even in United States, even in Canada, they have a very different phenotype. It's because of probably not only use of herbal treatment, healthy lifestyle, a lot of things that actually goes in and the genetics. So yeah.
Sir,
one question. Yes.
Sir, my question is about the curcumin. Sir, does it need any addressing? It should be used as such.
Pakistan में तो सबसे pure healthy मिलती होती है.
Yeah.
In capsules मिलती है.
At what dose, sir?
So the dose that is recommended is about 1,000 milligram or 1 gram twice daily. So typically we start with 500 milligram or half gram twice daily, and if they tolerate, we go to 1 gram BID.
So let's move to the next. So the next case is 52 years old man with history of ulcerative colitis for the last 20 years. Currently, he is in remission after husband and mesalamine. On surface colonoscopy, there was a lesion with high depletion. There was a lesion with low-grade dysplasia and Tauseef multiple biopsies from the area were taken. Otherwise normal. The question for discussion: how would you manage a patient with ulcerative colitis who has been found to have low-grade dysplasia and Tauseef using routine surface colonoscopy? So the question about dysplasia.
So I think I'll start to answer this one. Is the patient, if you go back to the actual patient description, so this is a 52-year-old male with history of UC for 20 years. So that tells you that it's a very long-standing ulcerative colitis. You got the patient in remission with azathioprine and mesalamine, and you're performing a routine surveillance colonoscopy. So this is another key thing, that patients with long-standing ulcerative colitis, you have to do their surveillance colonoscopy. There is a big debate when you need to do those surveillance colonoscopies, and I think guidelines have moved from annual colonoscopies to every 3 years to every 5 years. So if you look at some of the guidelines, and this is how I actually tell my patients, if you are in the United States, the United States experts recommend annual surveillance colonoscopy. You go to Canada, they recommend every 3 years colonoscopy. You go to UK, they are now recommending even every 5 years, as long as you are in remission. It's a different story if you still have active inflammation, then you may have to do it early. So if you are doing a surveillance colonoscopy and you have found random biopsies, and one random biopsies from transverse colon is showing low-grade dysplasia. That also brings up a very interesting question. Last time I was here in Lahore and I was doing a colonoscopy, I was informed that it's very financially difficult to do different jars from different segments because the cost is very high. In the United States, when I do my colonoscopy, I put ascending colon in one jar, transverse colon in one jar, descending sigmoid and rectum. So I call it 6-jar protocol because I do terminal ileum also. So 6-jar protocol. So all I have to tell my endoscopy tech, initiate 6-jar protocol, and the tech would know that they're going to break 6 jars, and I'll just do each segment. But I heard from some of my experts from Lahore that it's difficult, so they usually do at maximum right and left colon. So then it will be very difficult to find out where was this low-grade dysplasia, which segment. So I don't know how to address that. You probably would know more than me. How do you do surveillance colonoscopy? I think the key thing is now that you have discovered a low-grade dysplasia and you got lucky that your pathologist actually tells you that there is a low-grade dysplasia. There are two things. By definition, a polyp is a low-grade dysplasia, a tubular adenoma. So if your pathologist don't know whether you removed a polyp or it was a random biopsy, a tubular adenoma by definition is a low-grade dysplasia also. So it's very important how you report your colonoscopy and discuss with your pathologist. And now if you have found one segment, one area, it may be worthwhile. I don't know if chromoendoscopy is here or dye-based endoscopy is here. Like sometimes you use this indigo carmine or some other types of dye that you can use to actually see if it is visible dysplasia. If it is visible dysplasia, you can actually now do EMR, ESD to remove that area, and you don't have to do colectomy. About 5-6 years ago, the answer would have been, you found a dysplasia, do colectomy. And now the answer is, if it is one area, you may want to perform a high quality colonoscopy with excellent bowel prep, either use a dye or use NBI. If your scope can do NBI, do NBI. Studies have shown that NBI on the colonoscopy or the chromoendoscopy have equal outcomes. And then see if you can remove this dysplastic area. If not, then probably a patient with multifocal, more than one area. And you can only discover that if you have done different jars. Then this answer would have been surgery if you have multifocal dysplasia. So I'll just stop here and see what are the other comments.
Regarding chromoendoscopy, it's not routinely available in Pakistan. Some centers do have sedative, but it's not a routine practice.
Scope NBI?
Few centers have NBI scopes, but not all of them. And we are striving our level best to improve the standard all over. Right now, when we purchase, like for this institute, we have purchased the Fujifilm LCI. The one is narrowband and one is the Fujifilm blue laser imaging BLI, which is equivalent to NBI. So we have the BLI scopes in KBU Hospital Research Center. In my private practice, I have NBI scopes with magnification, but I don't know if someone else have the BLI or NBI scopes. Like Dr. Tauseef Ali is here from South East, the surgeon here in the medical complex. Do you have NBI scopes?
So I have a question. Sorry to interrupt you. How frequently you ask patients to get surveillance colonoscopy? What's the number one acceptance, and what is the common practice here? If someone is in remission like this 52-year-old on azathioprine, mesalamine, coming to your clinic, what type of discussion you have with the patient to recommend colonoscopy, and what is the acceptance rate for that?
In Pakistan, most of the times the UK model is followed, which is every 5 years. Like from initial diagnosis, after 5 years we do the first colonoscopy if the patient is in remission, and then we do it routine. We do not do very frequent colonoscopies unless the patient is symptomatic or the patient has some area of some other flavors.
I have a question. I have a question here. Audience की तरफ से नहीं आ रहे तो
I think we need to encourage them to ask questions.
So maybe because usually surgery happen in a predominantly medical symposium. So maybe if I can go back 10, 12 years, 13 years when I was training, so whenever you diagnose a patient with UC, so जो part of the counseling होती थी वो ये होती थी कि your first 10 years from the point of view of developing malignancy in the colon, the risk is low, but from 10 years onwards, there's incremental increase in the risk of developing colonic cancer. और 20 साल तक अगर इसमें जो important चीज है इसलिए है 20 साल की ulcerative colitis है, तो by age 20 उनको strong recommendation होती थी to consider some form of surgery, either subtotal colectomy or total colectomy. So the question is, you pick up low-grade dysplasia. So do you take into account कि ulcerative colitis की duration कितनी है? Would you treat it differently if it's a 20-25-year history of ulcerative colitis, or if it's just 1 or 2 years history of ulcerative colitis, because the longer the history of ulcerative colitis, the greater the risk of malignancy. So does that influence the decision of whether you want to do surgery or continue medical management?
So it's an excellent question, and kind of like the evolution of our understanding also. As you said very rightfully, that I think even in this case, when we say remission, there are now different definitions of remission, right? So one is clinical remission, and one is endoscopic remission, and one is histologic remission, right? So what we used to think about the risk of cancer and malignancy was probably because we were stopping at symptomatic remission. We were not achieving endoscopic remission. We were saying the patient is doing well, let's just continue that. And the challenge was that now what we have learned, that because of the ongoing histologic activity and inflammation, by year 10, 20, they would develop a cancer. And that was what we discovered, that's what we were witnessing. But now we know that if you control their inflammation and you control their histology, your risk of cancer is becoming lower and lower and lower. So you will see that the risk of colon cancer, the risk of dysplasia is actually going down in Western world, despite having this disease for 20, 30 years. Hardly we do colectomies these days in the United States because now we have discovered a dysplasia. I cannot think of doing a colectomy on a patient with dysplasia if I look back 5 years now. Hardly I can see a patient. The only patient I would see going for colectomy for dysplasia are the patients who are either non-compliant or didn't have their medication optimized. Even in the United States these days, even in my practice, we don't stop at, as I was telling you, 3 buckets. We go to the 3rd bucket, which is healing. So if you talk to your pathologist, the way we do it is we look at the histologic scoring. There is a scoring system, it's in the textbook, it's called Gibbo's score. So it actually look at the percentage neutrophil infiltration in the mucosa. And the goal for histologic remission is less than 5% neutrophils. So if you're doing biopsies, your pathologists commonly tell you what? Active colitis, colitis in remission, quiescent colitis, chronic active colitis, chronic mild colitis. And I always struggle because if you send that slide, and I bet even in Pakistan you send that slide to pathologists, every pathologist will have its own way of describing colitis. You cannot tell from a pathologist whether this is, how bad is this colitis. All you are doing is looking at the endoscopy and yourself telling, ooh, this is bad, or this is getting better. And even that, there is not only inter-observer variability, there is an intra-observer variability also. I may have seen 3 worse colitis in my 3 colonoscopy. The 4th one may be a little lower and I said, oh, this is better. It may still be worse. So I think there are a lot of variability. So if you can train your pathologist and you can ask your pathologist, can you actually tell me what is the percentage neutrophil infiltration is? Because if I see 20% neutrophil infiltration, it means there is still activity going on. This is the patient I may want to ask to do a colonoscopy again in 3 years or 5 years. Now, if the neutrophil infiltration is less than 5%, it means they're in deep, deep, deep remission. Their risk of colon cancer is almost like a normal person. And they may need to be surveyed just by fecal calprotectin every 2 years or 3 years or something like that. Could be a negotiable thing. I don't know if I answered your question, but I was just giving a little bit of perspective of the goal of therapy, and if you achieve a higher or deeper goal, I think your risk will be lower also.
One question. Find someone with low-grade dysplasia, do you change your strategy of doing colonoscopies?
So if we find a low-grade dysplasia, it's a unifocal in one place. If it is resectable, I will resect it. If I cannot resect it, I will send it to my advanced endoscopist to do ESD or EMR. If it is non-resectable and the colon itself looks fine, there is no underlying inflammation, it was just an incidental low-grade dysplasia, and I know that I did not take a polyp, and it was purely, truly low-grade dysplasia, then I might bring the patient back in about 2-3 months and do a detailed colonoscopy with either NBI or chromoendoscopy.
If everything looked fine, I do extensive biopsy, especially the area where I found that low-grade dysplasia. If I don't find any low-grade dysplasia, I usually then bring them back again in 6 months. If that's fine, I bring them in 1 year. 1 year, 2 year, 2 year, 4 year. So I double the interval every time. That's one way to handle it. Second, some patients are very nervous. You tell them that you have dysplasia and there may be some other areas where there may be dysplasia. They may say, well, I better just get colonoscopy. And there's a third category where patients, even in United States, patients have insurance issues, they have deductibles, co-pays, and it may become expensive to go that many colonoscopies. And they say, well, I don't want to do colonoscopies and I don't want to take a risk, so I better get a colectomy and J pouch and just get over this disease.
One question. So you talked about histological remission. So I have when we should do the first colonoscopy to check for histological remission after starting patient on treatment after diagnosis, and then how frequently should we check for histological remission?
I think I'll give you my answer that how we practice in the United States, especially in our even in the United States, you will see that there's a varying practices depending on your expertise and your patient population as well as how you practice. And I think this is an excellent question where there's an opportunity for Pakistani physicians to write guidelines, like what is good for us here and how should we manage. Happy to contribute and help write guidelines like this so that there is at least some kind of a standardization of how we should do that. Histologic remission is still kind of aspirational goal. You cannot achieve in everyone, but it's something that you might need to strive. If you again look at the 3-bucket strategy, the third bucket is healing, that is the histologic remission. Your question is, you got a patient with ulcerative colitis, you start on treatment. These days, since you have fecal calprotectin, I typically do see fecal calprotectin at month 3. Fecal calprotectin is not down, I will optimize the dose. Go up on the dose, do something. Then do it again at 6 months. And around month 9, I will do my first colonoscopy to see how my drug is working in terms of endoscopic healing or histologic healing. And after that, if the results are good, satisfactory, and I'm satisfied that the calprotectin is less than 200, my endoscopy has shown a lot of improvement, and my histology is also getting better, then I will do my next one in about a year. After that, these first 2 ones, then I will increase the interval depending on patient's acceptance, affordability, financial status, and have that discussion with the patient and see when should we do our next one. But at least in the beginning, I would do first one is the index colonoscopy. The second one around month 9, if possible, and then the one a year after that. So these are kind of like my standard protocol.
Thank you, sir. Sir, that's so meaningful and great discussion on how to appreciate.
I have a question from sir. Sir, do we change treatment if there is endoscopic remission is not achieved? So, and the patient is in clinical remission. Histological remission is not achieved, but the patient is in histologic, in endoscopic and clinical remission. So, do we change the treatment?
So if your patient is in clinical remission, endoscopic remission, just showing histologic activity, the standard answer for board exam, for guideline purposes is no, you don't do anything. But if what I do, let's say if my patient is on a medication and there is some histologic activity and I have the luxury of checking drug levels, I might optimize their dose. Someone is in 2.4 mesalamine, I may tell them that you may want to go to 4.8 to see if I can achieve that histologic remission, because it may not matter now. But as you are seeing in this case, and as we were mentioning, that 20 years of that histologic activity may then take its toll and may cause harm. So if you are projecting for that long-term goal, you may want to, at least for now, until we have a better understanding, optimize the dose. If the dose is already optimized, then I think I would just leave that alone.
Sir, if हमारे पेशेंट सर इधर अफोर्डेबल नहीं होते ना सर, ना वो फीकल कार्पोरेट नहीं कर सकते हैं और इस तरह पेशेंट आते हैं ना, तो इसमें जो CRP है या ESR है, ये उसकी कुछ वो है कि वो रिप्लेस करे फीकल फ्लैश प्रोटेक्टिंग की, या ये हेल्प कर सकता है पेशेंट मैनेजमेंट में?
So the challenge with CRP is it's very non-specific, right? अगर आपको थोड़ी सी चोट भी लगी है तो CRP बढ़ जाएगा। और मेरा अपना जो एक्सपीरियंस है कि बेसलाइन ESR और CRP पाकिस्तान में वैसे थोड़ा सा ज़्यादा रहता है, क्रॉनिक इन्फ्लेमेशन वैसी है, तो आई डोंट नो हाउ रिलायबल दैट वुड बी। अगर फीकल कैलप्रोटेक्टिन एक्सपेंसिव है, जो कि आज से 4 साल 5 साल पहले इवन इन यूनाइटेड स्टेट्स insurance will not cover fecal calprotectin, saying that it's an experimental, and the charge for fecal calprotectin for a patient was $2,000. So very expensive, even in the United States, until very recently, in 1 or 2 years, that insurance is approving calprotectin. The other thing to look for in those patients who are actually not very good in telling you their symptoms, because you will see patients also, they cannot describe their symptoms, or they are very shy of telling you, is look for iron deficiency anemia. If they have iron deficiency anemia, or just looking at their MCV, you can actually say that there is some inflammation. There's something going on, because iron deficiency anemia is also an indication for inflammation. Low albumin is also an indication for inflammation. So low albumin, low MCV, low hemoglobin can also be your indirect markers that can tell you that there is still something going on.
Thank you, sir. The participants are requested to write down the question take up after the conversation. So let's move to the next.
So are we asking questions? If the students are not asking questions, I think we need to ask them questions, right?
At the end of the day. So the fourth scenario is 30-year-old female patient with history of diabetes and remission. She is in remission for the last 2 years. Visits for preconception counseling with concern about medication safety, risk of flare in the pregnancy, and mode of delivery. Question for discussion: how should medication be managed in patient with ulcerative colitis and for pregnancy to ensure disease remission and fetal safety? Question number 2: what factors influence the mode of delivery and pregnancy pregnant patient with ulcerative colitis?
So I think let me ask this question to the students now. I think it's a pure guess, right? So let's do it. See if someone can answer this question. So if you have a patient who is having ulcerative colitis, doing fine, comes to you and say that I want to get around, or comes to you pregnant and ask you, do I need to stop my mesalamine and azathioprine? What will be your answer? So raise your hand if you say, yes, stop both of the medications. And raise your hands if you say that continue mesalamine, stop azathioprine. Okay, so we have one student that is saying stop azathioprine. This is a very good question and clinical scenario. Even in United States and Western world, young females, they are very hesitant to take medicines because they are concerned about the pregnancy and the effect of drugs if they get pregnant. Even young girls who are 18, 19-year-old coming with their moms and parents, they become really hesitant that, oh, we don't want to start medicine because if she gets pregnant, we don't know the outcomes. So the answer is that except for 1 or 2 medications, most of the medications are safe in pregnancy. And one of the things we tell all our patients that you need to be in remission before becoming pregnant. And it's very important when you see a female patient in the practice and you are talking to them about the first 2 things I described, symptoms and inflammation, don't correlate. So just don't feel like you're doing fine if your symptoms are good. We need to bring your inflammation down. Second, the 3 buckets. The third thing I talk to my female patient is pregnancy. You can have pre-planned pregnancy, you can have unplanned pregnancy. So the key thing is you don't want to start them on a medication that you have to stop. Because by the time you will find out that they are pregnant, it's already, 5-6 weeks of pregnancy. Organogenesis is already
happening. So now if you ask them to stop the medication, it doesn't make any sense because the damage has already occurred. Because the risk is the congenital malformation. The other risks are not as great as the risk and the concern for congenital malformation. So it's very critical. The good thing and the good news that we tell all our patients, whether it's mesalamine, azathioprine, or even all biologics, they are all safe during pregnancy. There is no need to stop. The only thing is if you are pregnant and now you are having a flare, we do not recommend to start azathioprine. And do you know why we don't want to start azathioprine if someone is pregnant? What are the two side effects of azathioprine that you must tell your patients? Any volunteer? So I know that we use a lot of azathioprine in Pakistan, right? So I don't even know if these side effects occur in our patient population in Pakistan, but these are the two side effects that we tell all our patients in the United States. So the first one is leukopenia, right? So you can get neutropenia. And if you remember your pharmacology, that there is some metabolite 6-TG and MMP and all those pathways can lead to, some people have that metabolism, xanthine oxidase, that can cause shunting of more 6-TG and leukopenia with azathioprine. So leukopenia as well, right? You don't want your pregnant patient to become leukopenic. And also remember azathioprine goes in through the placenta to the fetus. So fetus can also get leukopenic and anemic also. The second thing is idiosyncratic pancreatitis. That is a side effect of azathioprine. A lot of patients can present with pancreatitis. It's not dose dependent. You cannot predict it. The last thing you want is a pregnant female getting pancreatitis. So that's why in the United States we shy away using azathioprine during pregnancy. Before pregnancy, if they are on azathioprine and are in stable dose, you continue that. So the answer to the question is you continue the same medication without stopping throughout the pregnancy. About 5 years ago, there was an expert opinion that maybe the biologics, if you are on infliximab, adalimumab, all these biologics, maybe stop them in your last trimester. Deliver the baby and then give them, or stop the last dose, because these medications also transfer through the placenta to the baby and you don't want to expose the baby with biologics. The studies have now shown, and the general consensus now is that you continue all these medications. You don't need to differentiate between pregnant and non-pregnant patient when it comes to the management, except for 3 medications. Can anyone guess those 3 medications that you do not want to give a pregnant IBD patient? So it's good that you ask questions, otherwise I'm going to keep asking you questions. So one is methotrexate, right? So you do not want to give methotrexate to a pregnant female. The other 2 ones. So you don't want to give JAK inhibitors. I know tofacitinib is available in Pakistan. So you do not want to give pregnant female or a female who is planning to become pregnant tofacitinib. So that's an important thing. Sometimes you just like, okay, you're flaring up. You don't discuss that. But you have to discuss this with that female patient that you cannot become pregnant if you are on tofacitinib. And then the third one is, which I don't think so is available here, is S1P modulators. So S1P modulators are ozanimod and etrasimod. These are your S1P modulators. And you don't want to give those to pregnant female. But yeah, it's not available. So the rest you can give, all biologics, everything else that's available, you can give those medications to the pregnant female. The good thing, the good news that actually I thought I would ask you the question, but now I'm going to answer myself. Pregnancy is an immunosuppression state by default. So usme aapko वैसे the risk of flare, the risk of activity actually goes down. Because that by default pregnancy is an immunosuppression state. Your TNF alpha levels actually go down in pregnancy. The only risk you get in pregnancy is as you
advance your pregnancy, and uterus size is increasing, it's compressing your intestines and can cause some more annoying symptoms from constipation to abdominal pain. Majority of the patients, actually there's a rule, it's called rule of 3, that you tell all the patients with pregnancy. 1/3 will remain the same. 1/3 will actually feel better, and 1/3 can get a flare. So you have to really be careful about that 1/3 of the patient population. Even that 1/3 that gets worse you can save them if before pregnancy. I don't know how practical it will be in our culture here, but in the United States we tell them you must get one colonoscopy before planning for pregnancy or conceiving, because if you are in remission, your chances of outcomes will be a lot better. If you have active disease and you are pregnant, you are at risk for 3-4 things. Short for gestational age, SGA, growth retardation, low birth weight. So these are all your risks to the baby if you have active inflammation. So being in remission at the time of conception actually have better outcomes for both mom and for the baby.
So the next question is what factors influence
So the quick answer is it should be dictated by your OBGYN. So whatever your gynecologist, so there is no indication for C-section except for perianal fistulas. The rest should all be, the way I tell my patients that if you look at the risk factors, and we talked about this, the epidemiology, there is a risk of transmitting UC and Crohn's in your babies. That risk is about 3 to 5% in Western population. That there is that risk. You can minimize that risk for many things. And few of the risks relate to the pregnancy also. Vaginal delivery has a lower risk of transmitting Crohn's and colitis to the baby as compared to C-section. Breastfeeding, it decreases the risk of Crohn's and colitis in the baby also. So we encourage our patients to go for a normal vaginal delivery and for breastfeeding, because both of these things have shown to actually help with the gut microbiome, and that actually is good.
Next is.
Thank you, sir. It's so meaningful discussion, and I hope that you support our audience. So let's go to the next series. 45-year-old female patient with Crohn's disease for the last 5 years, with intermittent bleeding fistula managed for the last 3 years, current symptom 3 months history of the pain and discharge. Current treatment includes infliximab monotherapy. Findings on the left to be shows active colitis. Partial examination revealed fistula opening, otherwise unremarkable examination. Discussion: what modification to her medical therapy should be considered for better disease control? Second question: what role does surgical intervention play in the management of urinary Crohn's disease?
So I'll just give a quick answer to the question about, the first question was the medical management. So what we know now, as you can see that even on the colonoscopy, that proctitis is the leading cause of perianal fistula. So it's very important to make sure any patient with perianal fistula that you do their endoscopy and see if there is still proctitis. It means that inflammation is not adequately controlled. Studies have now shown that you have to give them more infliximab if they have perianal fistula. You want to really push the infliximab levels to 25 or even higher to help them with perianal fistula. I know it's not an ideal situation here in Pakistan where the affordability and the accessibility to infliximab. So there are some very nice papers showing the role of antibiotics, especially ciprofloxacin, more than metronidazole. I, in my practice, use both Cipro and Metro as an adjunct therapy to infliximab. Studies have actually also shown that if you combine antibiotics with biologic therapy, you get better results. And it's a very joint effort between the physician and the surgeon. You probably should put a seat on for the perianal fistula or engage your surgeon the very first thing your surgeon is going to ask you, you need to control medically the proctitis. As long as the proctitis is there, it's going to be very, very hard for the perianal fistulas to heal. So we probably need to develop some strategies in very, very, very difficult patients. I have asked the pharmacy to compound tacrolimus suppository. So you can use tacrolimus suppository to control the proctitis. I don't know if tacrolimus is available in Pakistan. I probably think that it will still be cheaper than biologic therapy. And once again, tacrolimus may be another drug of choice to consider that may be even more affordable than infliximab. Surgical intervention, I think you need to engage your surgeons, and I'll see what you have your experience with that. But we engage our surgeons right from the beginning. We put the seat on, we start them on therapy. Once the fistula is dry, then the surgeon either take the seton out or perform surgery. And there are so many surgeries now available, from plug, flap, laser for the fistula healing.
Just on the surgical side, there's a saying that if you have more solutions or options for a problem, that means that none of them are working well. That's why you have so many solutions. So there are 5, 6, 7 different types of surgeries that we do for periatric fistula. And the main reason is that the response rate is poor. Regardless, it depends on the patient, but it also depends on the surgeon. From a surgical point of view, if there is active disease, so we will run away a mile. So unless it's the very, very last and you've exhausted everything and it's socially not possible for the patient to continue, but because of the failure rate is so high, you would run away a mile with active disease from doing anything surgical in Crohn's fistula.
The only thing, sometimes we make an exception and we actually bring our running away surgeon back to the table, is we ask them to do a diverting ileostomy. Okay, आप divert कर दो सही है, ताकि maybe it actually gives a little bit of chance of healing. But again, once you divert it, the chances of revision and takedown and fistula will come back again. As you're saying, that when you have, it's actually good, I will remember that now, when you have multiple solutions, it means nothing is working, and that's why you have multiple options. But so the other option is we ask the surgeons to do diversion, so that because the perianal fistula is very debilitating, especially to the female patients. So we sometimes offer them a diversion to see if that can heal their perianal fistula.
Next.
Next is 26-year-old male. Currently, he is on azathioprine and adalimumab with clinical and endoscopic remission. His recent symptoms include fatigue, unintentional weight loss, 5 kg in 3 months, poor appetite and bloating. On examination, BMI is 18.5, signs of malnutrition, mild muscle wasting and pallor. Lab investigation reveals HbF 10.5 gram per deciliter, creatine 15 nanogram per ml, albumin 3.8 gram per deciliter, vitamin D low with low vitamin B12 level. Question for discussion: how do you screen for malnutrition in patients with IBD?
So nutrition is very, very important in IBD. A couple of things that I'll make comment if you go back to the case. Fatigue. Very common in IBD patients. Fatigue is actually common in all of us in medical profession, right? We all are fatigued all the time. So in IBD, there are some studies coming up showing that fatigue can be related to thiamine deficiency, and giving them high dose thiamine, which is I think B1, right? Vitamin B1. You give them high dose B1 to help them with fatigue. So one of the screening questions that we ask our patients all the time when they come to the clinic, so if you look at my template, the questions that I ask every time, one of them is about fatigue. So if there is a fatigue, then and there is no active inflammation, then I do recommend them getting thiamine on the board. The other reason for daytime fatigue is poor sleep, and daytime sleepiness and fatigue. And poor sleep can happen because they may be on steroids. So also try to bring that knot together. that fatigue could be because of that. Third reason of fatigue, hypothyroidism can also happen in IBD patients. So make sure you're screening for thyroid diseases also. Going back to the nutrition, the other thing is iron deficiency anemia. If you look at the standard definition of iron deficiency anemia, it's the ferritin, right? So if your ferritin is less than 100, that's iron deficiency anemia. But remember one thing, in IBD, the definition of iron deficiency anemia, if you have active inflammation, is sorry, I got it wrong. So if you have ferritin less than 30, that's the definition of iron deficiency anemia in normal people. So if you have a ferritin of less than 30, you are iron deficient anemic. In IBD, if your ferritin is less than 100, you are iron deficient anemic. So the threshold is higher. So it's not 30. Even if your ferritin is less than 100, you are iron deficient, as compared to a normal population where 30, 35 is the definition. So make sure you remember that and you offer them iron supplement. And the studies have now shown that giving them iron supplement every other day is better than daily iron supplement. The absorption of iron is better if you give iron every other day than every day, because it has to do with the saturation. The other thing about iron deficiency is that if you have active inflammation, so let me ask this question to the trainees. What are the causes of iron deficiency anemia in IBD? One is obvious, I'll answer that, right? Bleeding, right? Loss of blood. What are the other causes of iron deficiency anemia? Iron deficiency anemia causes an IBD. Okay, let me give you a guess or hint. Where is iron absorbed in your intestine? No, which part of your intestine iron is absorbed? Duodenum, right? Duodenum. So Crohn's disease of duodenum can cause iron deficiency anemia. So if a Crohn's disease patient is coming and saying, you check their iron deficiency, you may want to do an upper endoscopy to make sure they don't have Crohn's disease of the duodenum. Or duodenum. So there are two. What is the third cause? Let's say the patient is having ileal Crohn's disease, not having any bleeding, but they still have active ileal disease. They don't have duodenal disease, and they're still iron deficient. What could be the cause of that? That's a postgraduate question. So there is something called hepcidin. So hepcidin decreases the absorption of iron. No matter how much iron you give, if you have hepcidin problem, it will inhibit the absorption of iron from this duodenum. It's kind of like insulin and blood sugar, so hepcidin and iron. So read about hepcidin and iron cycle. So in active inflammation, when you have interleukin 6, interleukin 1, TNF-alpha, they're elevated, your hepcidin blocks the absorption of iron from the small intestine. So even if you are taking iron, even if you are not bleeding out, even if your oral iron intake is good, you can still be iron deficient. These are the patients that you may want to give them IV iron to help them with their fatigue. And believe me, if you bring their ferritin close to even 50 or 60, you bring their hemoglobin above, they will be so thankful to you because they will get the energy back. And one of the problems with IBD patients is that they have very low energy, they're fatigued and tired all the time because they are depressed, because they are anemic. So at least addressing their fatigue through iron deficiency anemia is important. Now the last part I will address is the screening for malnutrition. So malnutrition is a very big topic. If any one of you on Twitter or LinkedIn, about 2 weeks ago, I actually posted this, the malnutrition, the types of malnutrition. So malnutrition is not just low BMI. So if anyone coming with a weight loss of about 5% in 3 months is malnutrition. Anyone who is looking fine and healthy has sarcopenia, muscle wasting. That is malnutrition. Obese patients can also be malnutrition. So weight gain is not like if someone is healthy, they can still be malnourished. So keep that in mind, the types of malnutrition, the presentation of malnutrition. It's a whole different actually lecture on malnutrition, but keep in mind that screen for malnutrition, common things are iron deficiency, vitamin D. Studies have now shown that vitamin D affects your inflammation. Even if you ask your cardiologist, they will tell you that vitamin D has an effect on metabolic status. Vitamin D plays a role in liver. Vitamin D plays roles in inflammation also. So at least optimize your vitamin D to 35 plus. Ferritin, try to go as close as 100 or try to correct their hemoglobin. B12, very important to check in Crohn's disease because where is B12 absorbed? Which part of the intestine B12 is absorbed? Terminal ileum. So Crohn's disease typically attack terminal ileum. So make sure you. I have a patient who came to me one time with what is the common symptoms of B12? One of the common symptoms of B12 deficiency. Do what? Okay. What the B1 neuropathy.
Symptoms of
Symptoms of the neuropathy, tingling and sensation in their feet. That's common in B12. So sometimes you ask the patient because metronidazole can also cause the neuropathy. So long-term metronidazole therapy. So it's very important to check for if someone comes, history and physical examination, despite all our advancements, history and physical examination, as your professors always tell you, do not undermine that. You can solve lots of problems by taking a good history and a good physical exam. So if ask the patient if they're having numbness and tingling in their feet, and they will tell you, yes, I've been. So check for two things, B12, and see if they're taking long-term metronidazole. So if they're taking this, you may want to correct that.
Thank you, sir, for so shallow and detailed discussion on how to manage and approach patient, the nutrition aspects of patient with ulcerative colitis or Crohn's disease. So at the end of the session, there will be lunch programs, so other participants are requested to stay with us. Let's move to the next session, next question.
I think this is the last one.
Last one. This is the last one. Later on, we can have comments as well. Just finish this.
Lunch.
Okay. Sir, the vital code work with history of Crohn's disease with ileocolonic involvement, presenting progressive joint pain and stiffness for the first 6 months. Her symptoms include pain in knees, ankles, and wrist, morning stiffness lasting over an hour, no recent IBD flares, stable and medaling mark. Patient concerns: why do I have arthritis even when my gut symptoms are controlled? So, question for discussion: how would you address her concerns about arthritis and IBD? The second question is: how would you manage her arthritis in context of stable Crohn's disease?
Question for the students and the trainees: how many patients with IBD have extra intestinal manifestation? 10%, 40%, 80%. Those of you who say 10%, raise your hands. 40%, 80%. It's okay to be wrong. It's okay. Totally. That's how you learn, right? So the correct answer is about 40%. So 40% of IBD patients get extra intestinal manifestation. The other important thing for extra intestinal manifestation to remember is that they can actually present first, even before the diagnosis of IBD. They can have skin problems, joint problems, eye problems, and many times in my practice, I get a referral from an ophthalmologist because the patient had uveitis. Many times I get a referral from a rheumatologist because they have arthritis. Many times I get a referral from a dermatologist because they have psoriasis. So psoriatic arthritis, psoriasis. What are the other two conditions? Derm conditions, extra intestinal conditions in IBD. The common ones that is all textbook. I'm pretty sure it's in Harrison and Kumar, I think you still read that, right? Harrison and Kumar. So, and skin manifestations in IBD. Erythema nodosa 1 and pyoderma gangrenosum. So these are two. Erythema nodosum relates with disease activity. Pyoderma gangrenosum does not relate with disease activity. So these are two. The third one, what is one skin condition that can happen because you are giving a patient a medication for Crohn's disease or ulcerative colitis? A skin condition that is induced by an IBD medication. And actually that IBD medication is used to treat that disease also, skin illness. Psoriasis. So, you know, anti-TNF therapy is used for both IBD and psoriasis or psoriatic arthritis. But paradoxically, infliximab and adalimumab can cause psoriasis also. So it's called paradox reaction. That in fact you give infliximab to treat psoriasis, but if you have an IBD patient, you are giving them infliximab, they can get psoriasis because of infliximab. It's called paradox reaction. It's something new we learned in the last 5 years about paradox. So we got skin conditions covered, and we learned about pyoderma gangrenosum and erythema nodosum. Erythema nodosum most commonly associated with Crohn's or ulcerative colitis? Crohn's. Pyoderma gangrenosum is associated more with the ulcerative colitis. Erythema nodosum, you treat Crohn's disease or colitis, you get better with erythema nodosum. Pyoderma gangrenosum, you have to treat independently. Okay, now we go to the joints. So there are two types of joint problems, axial and peripheral, right? So axial, like spondyloarthropathies or spondylitis, they sometimes respond good to anti-TNF therapy, not to the other medications. Peripheral arthropathies actually gets better when you control the disease. So if the patient is complaining of arthritis, you have to make sure that their disease is under control. If the disease is not under control, focus on the disease. You get their disease under control, their arthritis will get better. So that's your arthritis. And then the eye conditions. What is the eye condition that can happen in IBD? And the third one, the dangerous one, uveitis. So uveitis, scleritis, episcleritis, these are the 3-1, and the dangerous one is uveitis. And the treatment for uveitis is also anti-TNF therapy. So sometimes when you look at extra-intestinal manifestations, you can select your therapy based on what type of extra-intestinal manifestation they have. For example, if someone has IBD and joint problems, what would you choose in terms of biologics? Anti-TNF therapy. If someone is having skin problem and they have IBD, you would choose interleukin-23 therapy, which is, I know it's not available here, but maybe it will come in an exam or in your textbooks, interleukin-23, for example, ustekinumab, risankizumab, mirikizumab. So these are the 3 interleukin-23. Actually, there is a third one now also, gozolkimab. So there are 4 interleukin-23 therapies now. Very good for skin. And this is something that I'm talking about in my lecture also, that how we have now evolved in our understanding of extraintestinal manifestations and different inflammatory pathways. That their TNF pathway affect your joints and your IBD. Interleukin-23 pathway affects your skin and IBD. So sometimes you select therapy based on their inflammation. This patient didn't have any active inflammation. So her arthritis was separate. And you may want to treat that arthritis separately. But one thing that you have to remember, if someone is on infliximab, adalimumab, coming and telling you their joints are getting swollen, especially when they give themselves an injection or infusion a few days later, they get swollen joints and it hurts. What could be wrong here? They may have developed antibodies to these proteins, because these are protein-based therapy. And they can have developed something called serum sickness or lupus-like reaction that can all happen with biologics also. So don't forget about the side effects of therapy also. So this patient may be responding to therapy, but may be having side effects, so you need to screen for that. And second, it may be an isolated, unparalleled to IBD, and you have to treat them separately. And one of the cheapest medication that works really good for arthritis is our old friend sulfasalazine. So sulfasalazine really, I think it's available here in Pakistan. Right? So sulfasalazine really is good, besides hydroxychloroquine, black chloro. So these are good medications to control arthritis in IBD. If you don't have the ability to go on advanced therapy, even tofacitinib is very good for arthritis. There is one IBD medication, and again, questions for postgraduate students. One IBD medication that works only in the gut, so it will not be able to control extraintestinal manifestation unless that extraintestinal manifestation is a spillover from the intestinal inflammation. Do you know the name of that medication? The one IBD medication that is gut specific. It's a biologic therapy or advanced therapy. It's called anti-integrin alpha 4 beta 7 inhibitor. Its trade name is Entyvio. It's anti-integrin. So if you look at biologic therapies, you have anti-TNF, right? It blocks the TNF alpha. You have infliximab, adalimumab, cetrolizumab, golimumab. These are all your anti-TNF therapy. They are available in IV and now also available in sub-Q, majority of them. So this is your anti-TNF class. Good for joints, good for IBD, good for uveitis. Then you have the other class, which is interleukin 23 inhibitor. You have ustekinumab, mirikizumab, rizulkimab. These are all your interleukin 23. They are good for skin. And then you have your third biologic, which is your anti-integrin. If you remember your pathology, a little bit of pharmacology, there's MADCAM, integrin on the epithelium, the lymphocytes attach, they roll over it, and then they go inside. So that rolling, tethering, trafficking happens with integrin receptors, alpha 4 beta 7, and that's how they move and block the entry of white blood cells into the gut, and that's how Entyvio or alpha 4 beta 7 blocker works. So that's your biologic class. Then your tofacitinib is your small molecules. So they are not biologics, they are not protein-based therapy. If it is not a protein-based therapy, the benefit is that there's no immunogenicity. You don't lose response because of antibodies. So among the small molecules, you have two drugs. One is JAK inhibitors. In Pakistan, you have tofacitinib. I hope one day you can get upadacitinib also, which is better than tofacitinib also. They're both JAK inhibitors. Filgotinib is also available in Europe. And then you have S1P. S1P is very unique. It actually blocks the lymphocytes in the lymph nodes. Doesn't let them go out of the lymph nodes. So they don't go in your intestine. So that's called S1P modulators. So that's the whole advanced therapies that are available for IBD that we use to block and control the inflammation.
Thank you, sir. Dr. Tauseef, when you were preparing for the membership, I just want to refresh my knowledge that IBDs transform into ankylosing spondylitis, or the vice versa. Is it still stands true that these are the diseases which would convert into ankylosing spondylitis?
Not to my knowledge. I think they coexist. I think that's where maybe you can get ankylosing spondylitis in the beginning, and then a few years later you develop an IBD. There is a risk for that, but I'm not aware that there is a current understanding that they morph into that. There is a concept of spilling over the inflammation. It has to do with your gut bacteria. It's a little bit high level understanding of immunology. Your gut bacteria have a peptide that when it stimulates the immune system, and you develop antibodies or you get activation, you develop these memory cells. The same peptide may be present in other immunological cells, your T cells that are present in other organs. And then your antibodies can go and attack those and trigger an inflammation in that part. There's one theory which is called spilling over effect that can happen, that you get an IBD or you get some insult in your gut that can then cause all the problems. So that's why I think our old grandparents used to say like all the problems are gut, so eat healthy. Ghee cow, ghee is actually now studies have shown is very good for gut microbiome.
Thank you.
Thank you.
I have a comment and then a question. You can tell Tauseef, very thankful for him. He's an excellent teacher because he actually enjoys it. You can see the excitement when he goes into the depth of all these explanations. So anyone who is doing gastroenterology trainings or anyone, I would strongly suggest to stay in touch because he's a great teacher. The question is related to the previous slide and case. जो malnutrition के जो symptoms हैं, कि not eating well, lethargy, weight loss, anemia, यही आपके जो symptoms हैं, especially gut के malignancy के. So you have your schedule for doing routine colonoscopy. Your next colonoscopy is say 3 years, 4 years, or 5 years down the line, based on your IBD protocol and how you're monitoring that. But you have unexplained symptoms like that. Does this change your routine for colonoscopy, thinking this patient might have malignancy? It's not having IBD is clear from that, but because these symptoms can be mixed with malignancy, so I'm going to change and do an urgent colonoscopy to rule out that.
It actually opens another can of worms again for me to talk about it. I'll try to limit myself. The weight loss, and then some of the B symptoms, right? So night sweats and then concern. So not only the inflammation in the gut and there's a risk of the colon cancer, you are on azathioprine also. And there's one malignancy that's common in azathioprine. Do you know which one? Yeah, so you have lymphoma. Lymphoma is skin cancers. वो तो obvious है बाज़ skin cancer की अगर आप screening नहीं करोगे अच्छी annual skin screening, you can miss even a skin cancer. I had one patient very recently who was on tofacitinib and developed cutaneous T-cell lymphoma. So annual skin screening is very important. And that patient luckily had a dermatologist, and it was the annual skin exam when they discovered they have cutaneous T-cell lymphoma. So going back to your questions and comment about all these questions, and that's why you remember I told you taking history is so important. If you are not going to ask about fatigue, if you're not going to ask about B symptoms and night sweats or loss of appetite, blood in stool, abdominal pain, unintentional weight loss, you are going to miss serious things, cancer, malignancy, not only in the colon. If you are on immunosuppressive therapy, you can miss lymphoma. If you're on biologic therapy, you can miss some other cancers also. So I think it's very critical that you need to keep an open eye. I have the luxury of performing lots of tests when I feel like I need to. Except that I also carry patients who are non-affording, they don't have insurance, and it becomes a challenge. But when you see these alarming symptoms and you can see that this is not depression related, a lot of IBD patients get depressed also, especially young females, they get depressed. So depression can cause loss of appetite, weight loss, non-specific symptoms of fatigue. So depression screening, malnutrition screening, and then as you are saying, malignancy screening is also very important.
I have a comment that as far as IBD or its complications are concerned, there is an alternative paradigm, and that is leaky gut, which has not been talked about.
that these patients, they develop leaky gut, and the toxins in the gut, they enter the blood, and there is immunological reaction, and that can give to symptoms in any system of the body, including brain fog, including arthritis, including any other extra intestinal symptoms of this disease. So do you comment on this also?
Yeah, I think leaky gut syndrome is kind of like the same thing when we talk about in mucosal immunology, permeability, increase in the permeability. And one of the things that I will talk about in my lecture, that this whole concept actually is very important, very critical. A lot of attention is being drawn these days on this concept, that if you look at, there's a Danish study from Denmark where they looked at babies, and they discovered that babies who have interleukin 4 low levels and interleukin 17 high levels are more prone to get IBD. They have looked at mucosal permeability as one of the things that is happening even 10 years before they actually get diagnosed with IBD. So this whole thing starts from the gut bacteria, the leaky gut. I think the million-dollar question is chicken or egg, right? Is it the gut bacteria that are causing the leaky gut and then they enter? Or is it the leaky gut happening and then bacteria go inside? We don't know the exact reason. Is it the inflammation causing the leaky gut and now the bacteria is entering? Or is it the harmful bacteria that are causing? There's a whole thing that I will be discussing day after tomorrow, microplastics. And you know, even the tea bag that you use, and when you, the hot water, the fiber from the tea bag leaks out, that microplastics. And we use a lot of containers that are made of plastics and paper and so there is a lot of studies showing that microplastics are actually increased in IBD patients. And that makes sense. And this whole concept of leaky gut and gut bacteria and gut microbiome is so fascinating to me. I can talk about for 1 hour and will not stop. But I will give you one example that kind of like validate, because you know, you talk about genetics. IBD can be caused by genetics. IBD can be caused by gut microbiomes causing this leaky gut, and maybe that's why sometimes IBS is called pre-IBD, like pre-diabetes, pre-IBD, because in IBS you also get mucosal permeability. So when I was in medical school, about the same time when you were in medical school also, I remember we were a class of 300 plus students, and we got one patient in medical ward with Crohn's disease. And we were so excited, we got our books open and, oh, this patient is going to get steroids and azathioprine, and we were reading about it. One patient in the ward, I think, I don't know, like 50 patients are in the ward, or 30, 40. So this is, I'm talking about 96, 97. Fast forward, 2011, I came back and I was giving a lecture at King Edward Medical University now. And they asked me to round on the patients. 60% of the patients there were with colitis or some kind of an IBD. And I was wondering, like, you know, genes don't change in 10 years. It takes hundreds of years to have a genetic mutations happen. So what happened in Pakistan that you didn't have IBD that prevalent when we were in medical school, and now I think all gastroenterologists at least have a handful of IBD patients. So what's happening? So my only joke, which probably has a reality to it also, when I was leaving Pakistan in 2000, the first McDonald's, I remember in Lahore, the first McDonald's, when I came in 2011, each corner there was a McDonald's. So the westernization of the diet, we changed our diet. We changed our gut microbiome. And I think that's where we are paying the price of not only getting more IBD, but all these autoimmune diseases, eczema, arthritis, this non-specific inflammatory conditions and fatigue all the time because of the westernization of the diet that has a profound effect on our gut microbiome and probably, to your point, causing this leaky gut syndrome.
Dr. Tauseef, I just want to know how frequently do you use these fecal DNA tests? Like, say, for example, if you can't plan a colonoscopy.
So fecal DNA, we use it for colon cancer screening. It has no role in IBD. So colon cancer screening, and not even in IBD for colon cancer screening, because the colon cancer pathogenesis in IBD is different. The mutations are different. It's not the classic pathway of getting colon cancer, which I remember is P53 KRAS mutation, and then you get colon cancer. In IBD, all these are bypassed. You just directly go to dysplastic, and dysplastic you get cancer. So the fecal DNA is not useful to detect colon cancer because it is a different pathophysiology or etiopathology to get colon cancer in IBD. But regardless of IBD, if you have a patient, we do screen them for fecal DNA, and if it is positive, we call it Orugard, which is our trade name for fecal DNA. And now actually we have a blood DNA test also that we do to detect DNA for colon cancer screening. But as a gastroenterologist, my heart is with colonoscopy. So I tell them that it is still better to do a colonoscopy than doing all these tests for two reasons. Number one, these tests are telling you if you have cancer or not. It's not going to detect small polyps. So I can actually remove those polyps before they become advanced polyps. And number two, that you can still have a false positive with these DNAs and it worries you. And if it is a positive test, regardless, you are going to end up with a colonoscopy. So why go the hassle of DNA test and then if it is positive, you do colonoscopy. If it is negative, you can still not show with 100% confidence that you don't have cancer. So it's better to just go for colonoscopy.
Also, comprehensive intent and accurate position.
Next last questions. Professor Ijaz.
Sir,
I think he left in 2 periods. And you saw only one patient, and then in 2011 you saw multiple. So would awareness be a factor in that?
Yes, I think that is also true that with more, so if you look at the epidemiology, right, the incidence increases because not only there's a true incidence, but also more diagnostic tests available, more awareness happening, more utility, like more, I remember doing a colonoscopy in 2000 was not easy. I mean, there were professors who would do colonoscopy behind the closed doors and would not let anyone look at your colonoscopy. I grew up in that era.
Kafran doesn't, until he gets it to the ileum.
So yes, so I think that probably also played a role. But I also learned, even now, when I talk to some of the other experts from Lahore and Karachi, TB is another problem here. That tuberculosis and differentiating between TB of ileum and the TB and Crohn's disease of ileum is still a big challenge here. A lot of patients get misdiagnosed or undiagnosed or wrongly diagnosed because of that.
Yeah, I have a joke, if you don't mind. I went into the ileum and I said, wow, Crohn's disease, when I came back, And Dr. Sadiq Shah, you probably know his name. He was laughing at me and joking about it. It was obviously tuberculosis.
Yeah.
So it's like
Yes. So you talked about diet and awareness and tuberculosis, but another thing which is new is this.
Yeah.
And is that the reason why your water bottle is full?
Yeah. I don't know. So right before coming here on Saturday when I was taking my flight, we had a patient education event. So every year we bring all our patients. So I have on my panel about 8,552 patients. And we try to bring as many as we can once a year. We give lectures to patients and educate them. So one patient asked a question about water. And actually her question was very interesting about, these days in America, I don't know if you do it here a lot. You put a filtration system in your kitchen, right? So it's called reverse osmosis. And she actually pulled up some studies showing that water is actually better than the drinking water. So I don't know if your question is the plastic or the water inside. So yes, the plastic and the microplastics are very dangerous. If you go and just Google, I'm not even going to PubMed, just go and type, or even go to Chat GPT or Claude or Evidence, wherever you want to go, and type adverse events of microplastic on gut health. You will find so much literature already there that we are not aware. And we don't have that awareness how these microplastics leach out and cause a lot of damage. I can tell you, my home, when I told this to my wife and she went to Google, because that's her to go, she believes in Google more than me. So all our utensils in our home are now stainless steel. Those little boxes, plastic boxes, are gone. So we all are using stainless steel now because you know, this is how you need to protect your next generation, your kids. And that's why you see a lot of problems in the kids, the health problems, is because of that. Going back to that, one last comment. There was a Canadian study showing that kids less than 2 years of age getting antibiotics are tenfold higher risk of AMD compared to the kids who don't get antibiotics. It was not the antibiotics for gut problem. It was mostly the antibiotics prescribed for otitis media and for upper respiratory issues. And if you go back and look, how many times, I don't know, I think it's probably true here in Pakistan also, how many times you take your kid to a pediatrician for eye problem, ear problem, the very first thing is you give them antibiotics. And how you are actually changing the gut bacteria in an early childhood that has so much harmful effect later on in life.
Sir, I have another observation, like Professor Tauseef Ali there, you were there, Dr. Ulcerative there, Mr. Mansari. Many workers, these manual workers who go to Saudi Arabia, many of the young people do suffer with ulcerative colitis. I don't know if you have this observation or not, but looking into their families, there is not a single member of their family being suffered with UC or their relatives are not. There is no family history. But when they spend some years there, they come back, and this is my observation. I don't know how you people observe this type of findings.
Very true. You see, it's the environmental change. Those are the people who belong to poor class, and these stuffs, these things, they are, the more you become, rich and early, you go to these. Poor people still, they take even the utensils, even not there, the stainless steel, they are just the vertical one, which they cut. So naturally, these all change, and in those, everything is so artificial and all those things that definitely we do that. This modern lifestyle is really, it's at the cost of so many health issues. So I totally agree that because when we were training, even as Sadek Shah was laughing with Professor Jasa, and this is very true that बोलते थे कि मैं आपको भी गिनवा सकता हूँ कि कितने Crohn's disease है पाकिस्तान में मेरे लाइफ में देखे. The same what we were doing, but now things have changed. So yes, the environmental change, environmental factors, all these, because the genetics, they won't change in decades, rather maybe, I don't know, maybe even in centuries. It's very long time for that to get changed, and then they click and manifest. This is all the environmental factors. So, and the environment doesn't mean what you see, it's just what to take or to inhale everything.
So one question. If you plan to step up to like the will you stop all other medicines, or will you overlap it for some time? And second question, if you plan to step up, how do you decide that I should step up, or I should try like a left colitis, I can try both routes, oral and topical basis?
So, if I understand your question, the question is if the patient is on salamine, not doing well, you go to tofacitinib. The patient is on azathioprine, not doing well, you go to tofacitinib. or you starting a patient with severe colitis right from the tofacitinib. So 3 different scenarios. If the patient is not responding to a medication and you're going to tofacitinib, I think there's no point of continuing that medication because that medication didn't work. So that's one rule that I tell everyone, that if the patient is on azathioprine, not doing well, we're starting tofacitinib, there's no point of continuing that. The patient, the same thing with mesalamine. Second question is, from mesalamine to tofa, it's very easy. You ask the patient to stop mesalamine, you start tofa the next day or the same day. Tofacitinib is very fast acting. Within 3 to 4 days, you will achieve the levels you want, so the therapeutic benefits, so you don't have to wait. The challenge can come with azathioprine when you are on a very high dose of azathioprine, because you may be pushing azathioprine to its limit and giving a lot of azathioprine. A lot of azathioprine could be even like 300 twice daily, something like that. So, and you have actually a little bit of leukopenia also now, and patient is not responding, and now you're going to tofacitinib. That's a little bit challenge. I would again stop azathioprine and start tofa, but I would very carefully monitor that patient because tofacitinib can also cause neutropenia and anemia. And actually, you don't give tofacitinib if your hemoglobin is less than 8. So this is a patient I would actually monitor their CBC. Maybe once you start tofa, you ask them, stop your azathioprine today. Tomorrow you start tofacitinib, and I want your CBC to be checked. If not, in 1 to 2 weeks, at least within a month, get another CBC done to make sure. That's what I would do. I would not have any washout period or anything else. This whole concept of washout is actually going away now. You just simply stop and start the new medication. You don't have to wait. You don't have to cross over anything. You just start the new medication. Because all these new medications, including tofacitinib, are so fast acting that you don't have to bridge them with anything.
With Crohn's disease, we have started on physiotherapy, but he is not responding. After 3 months, not responding in V1, and he is not according the inflation. So, is methotrexate an option, and how much patient respond to
So the data for methotrexate is really weak, and I think most of the time we use methotrexate as an adjunct therapy to a biologic, as a combination therapy. If someone is already failing a class of immunomodulators, so the immunomodulators are, it's called conventional therapy. So in immunomodulators, you have 6-MP, you have azathioprine, and you have methotrexate. I am not aware of any study where it has been shown that if you have not responding to one immunomodulators, how you can go to a second one and can still be safe. Having said that, I also know and acknowledge the patient population here, our South Asian population, is very different compared to the European. And that really opens up so many research projects. I mean, it's such an easy project to do, and then share experience that patients who do not respond to Imiran, they do respond to methotrexate. And this is our study from Pakistan. I am not aware of any study in US for the same notion that we don't wait, we actually just jump to advanced therapy after failing one immune modulators. But that may not be true in Pakistan. Patient may be having a good, same thing with tacrolimus. Tacrolimus is such a wonderful drug for UC. We don't use it. Our oncologists use it all the time here. So low dose tacrolimus can be another good drug that our postgraduate, if they're looking for a research project for acute severe ulcerative colitis, they can actually induce with tacrolimus and then can go on azathioprine as an outpatient rather than giving them IV infliximab. Patient is not responding to IV steroids. What should we do now? And I think someone did mention tacrolimus as an option, and for that, cyclosporin is another option. So these are the medications that we can use in IBD that may be even cheaper than going Prograf and things like that, maybe cheaper than biologic therapies.
I totally agree with you, and this is probably the extra role here. If you come across in everyday we practice some challenges, so one is bringing the challenge into notice, but second is just go have a small study, but bring your documented data. And this opens so many new windows. And this is the beauty of the clinical practice. So I will really...
No, I think that's exactly what Indians are doing, right? So there's so much Indian attention right now. This whole SIA, the South Asian IBD Alliance, if you look at was the main purpose was to collaborate. And if you look at the tacos study, very famous tacos study for tofacitinib in acute severe ulcerative colitis. Where did it come from? India. The enteral nutrition in acute severe ulcerative colitis. Where did it come from? India. Because the patients were getting IV steroids, not getting better. So they actually started giving them NG tube feeding, which I think we can do it here too, rather than going with infliximab. Tofacitinib, again, they couldn't give infliximab, so they thought, let's just do a study. So much opportunities with little direction that we can then publish the data and can so proudly say that instead of a Jerusalem protocol, we have a Peshawar protocol.
And you are contributing to the patient care. That's very...
Thank you so very much. It was a very nice mini symposium on IBD, and I'm sure all of us have learned a lot with a very elaborate discussion on the different aspects of management of IBD. We are thankful to Professor Tauseef for coming all the way from East to Peshawar. And I'm being chair of the organizing committee. I'm also very much thankful to all of the panel of experts who are here today with us. I'm thankful to the rest of the participants as well. After the ceremony now, we will have certificate ceremony and then we will have a lunch. All of you are requested to be seated, please. I will now officially, we conclude the session and we do this. Professor Nizam Ansar is here. I would request him to kindly present the sheet to our different panel of experts. Dr. Hamid, who is our medical director.